will probably be going against a lot of brilliant interventional cardiologists across the country and globe. So why say no to revival? We'll be discussing in the next couple of minutes, and thank you, Dr. Sheth, you've given me maybe extra 5 minutes. So we'll be looking at various aspects: mortality, quality of life, prognosis, and peri-procedure risk. So these are my conflicts of interest. So when we talk of revascularization, I think we just talk of epicardial coronary stenosis, and that is probably just the tip of iceberg. There's a lot of stuff actually in the myocardium which we don't look upon while we are treating these patients with ischemic cardiac failure. It can be acute, where the role of revascularization is well substantiated by clinical evidence. But in chronic heart failure secondary to ischemia, we have something going on around the microvessels. So we need to look into that. And that is where the role of guideline-directed medical therapy probably comes into. And till date, we don't have any randomized clinical trial which says with confidence that revascularization is going to prolong life or reduce hospitalizations, reduce the incidence of arrhythmias or sudden cardiac death. One interesting thing is that clinical outcomes are more dependent on the extent of non-viable myocardium rather than the viable myocardium, which we are always targeting when it comes to revascularization. So this is all the science behind revascularization. My friend already told about that. It's stunning in acute and hibernating in between and then scar. So if we intervene in the early stages of the disease, then probably we are going to get some benefit. That is acute heart failure. But as the time passes by, the contractile reserve and the muscles, they probably both decline, and once the damage is done beyond the repair, then probably it is difficult to document any mortality benefit. With revascularization, obviously we can get some improvement in left ventricular function, we can get improvement in symptoms, but does that translate to a good clinical outcome? I would say it's not absolute. So there are many changes at the level of myocytes, the cellular level, the mitochondrial level, which are occurring when a patient has ischemic myocardium. And identification of this probably is more important, and targeting this is more important rather than just opening up the epicardial coronary. And all these changes, they actually unfavorably influence the recovery of contractile function even after effective revascularization once the harm has been done. So PCI in acute versus chronic heart failure, I think acute, it is well documented. All patients who come with acute coronary events, if you revascularize at the right time, probably you're going to give a good quality of life, a long life, and a life without many drugs. But in chronic heart failure with reduced ejection fraction, it is debatable. Over the past 4 decades, we have been trying to prove that revascularization is going to do good to these patients, but the only data which is available in favor of revascularization comes from STITCH trial, which at the end of 10 years says that CABG is better. But we have to keep in mind, but the STITCH trial, when it was published, it showed actually increased peri-procedural mortality during CABG in these sick patients. The next question which we always focus and talk about is viability, but does that really matter? I would say no. These are the various studies which have taken into account viability: STITCH, HEART, Part 2, REVIVE, BCSI 2. None of them have actually shown an improvement in longevity of life if you test viability or ischemic burden and then revascularize. It is to note that it is very common to have non-ischemia related myocardial disease in addition to incidentally found coronary artery disease in the epicardial vessels. That probably might be contributing to increased chances of death. So this is one of the largest trials, randomized trials, which tested actually the option of PCI versus guideline-directed medical therapy, and it failed to show any benefit at the end of even 8 years. So why is it important when we talk of PCI and we are not getting the desired outcomes? There are many factors beyond what we think actually are. So the candidates for revascularization, a burnt out heart, you may revascularize but gain nothing. The risk scores, the viability, the ischemia burden, and we have to think beyond the epicardial coronaries. That is just 2 to 3% of coronary vasculature. I'll be showing you in the coming slides. What about the mortality benefit, improvement in LV ejection fraction, as well as the metabolic function? So this is the health status in that particular trial, and we actually failed to show any benefit in terms of mortality. When we talk of heart failure, it's also important to just pay attention to preserved heart failure. There also, these patients will have ischemic burden. That comes from the hypertrophied muscle and ischemia occurring at the subendocardial vessels, and that translates to increased mortality. And that is the reason why there are very few drugs which are able to actually bring down the mortality in such patients. So when it comes to India, I think cost effectiveness is one of the main factors, and we have this analysis and it very well says that PCI is not cost effective when it comes to revival in ischemic heart failure. So let's talk about data. The STITCH trial, more than 1,000 patients, no difference in mortality even at a follow-up of 56 months, but please remember, very high mortality peri-procedure in patients who underwent CABG as compared to guideline-directed medical therapy. REVIVE trial, PCI was not superior to optimized medical therapy. STITCH extension study, that was 10-year follow-up, there was a benefit of CABG, but that is negated by the fact that during the initial time period, we had many people dying because of the risk during procedure. And REVIVE BCSI2, we have already talked about. So what's more important, viability or non-viability? This actually sub-study from revived BCSI2 trial shows that it is the extent of non-viable myocardium which defines the chances of death in the coming times rather than the viable myocardium. So the more the scar burden, the more chances of symptoms, the more chances of sudden cardiac death, the more chances of arrhythmias. And that is why probably we have not been able to look at survival benefit with PCI. So the next question is, can we really revascularize completely either by CABG or PCI? I would say no. So this is ex vivo arteriogram of a normal heart, and these are the epicardial coronaries, which are just 3 to 4% of blood supply. What about the next 96% of blood supply? There is no universal definition, there is no consensus on optimal extent of revascularization, and no guideline discusses in detail what is actually complete revascularization. So this figure is very explanatory. If you carefully see, after 4%, there is a lot more occurring actually at the arteriolar levels, and it is the micro vessel regulation, it may be the metabolic factors, it may be the vascular factors. So we are just targeting 4%. That is the reason why we don't see any benefit. So what does revascularization actually offers? When we talk of heart team, I think we think of improving left ventricular function, and which should possibly translate to reduction in mortality, but it doesn't happen. We have seen this happening over the last many years from these trials, Courage trial, Orbita trial. None of them have actually shown any improvement in longevity. So do we really need to intervene in stable angina? Actually, Courage trial had same results when compared to PCI, optimized medical therapy was given. But those were first generation stents, the initial techniques, probably we were evolving in that. We had a meta-analysis, but you know very well that meta-analysis data can't be interpreted with surety because some of that can be registry data. So this is what is depicted in that. As there is increase in ischemic myocardium, the mortality increases. But we have not looked into this factor that what was the extent of non-viable myocardium. Probably that might have contributed to increased mortality. We can revascularize if we want to give angina relief, but believe me, with guideline-directed medical therapy and choice of correct anti-anginals, probably the angina can be relieved in more than 92% of the cases. And with PCI, incomplete revascularization is always going to be there, especially if you have a triple vessel disease in diabetics or with other comorbidities. And as you start putting more and more stents, we are going to land up having these patients come back again and again for in-stent restenosis, stent thrombosis, and the cost goes up. So what happens in left ventricular dysfunction? If we compare complete versus partial, probably complete revascularization does reduce a mortality to a little extent, but if you compare with optimized medical therapy, that does not hold true. So should we be going beyond just our ocular reflex? Yes, probably functional testing might answer this, but still, even if we do functional testing, what about the scar, the area which we can't revascularize? So those are the areas which actually define the longevity and mortality-free period. So is it that functional revascularization is going to give us complete answer? Maybe yes, but if you compare with the current therapy which is available for heart failure and ischemia, probably I would say both are at the same level. So these are various risk scores which we can use while doing a functional revascularization. But what about these subset of patients? We can't revascularize. This is a beautiful paper published in Canadian Journal of Cardiology, and it divides into 4 phenotypes. We can't revascularize them. So what to do with these patients? Probably then we switch back to guideline-directed medical therapy. We always tend to forget that there is a remarkable evolution in the therapies which are available for ischemic heart failure. So if you see the mortality benefit, there is an absolute risk reduction of 26% with these drugs which are available. And why do they fare so much better than revascularization? Because they are not just targeting the epicardial coronaries. We are going beyond that. We are going into the muscle. We are going into the microvasculature. And that is the reason why all these 4 pillars are considered a gold standard in therapy when it comes to ischemic heart failure. And sometimes we just keep on targeting the epicardial coronaries, the 4%, but then we forget about ischemic MR, VSD, arrhythmias, dyssynchrony, and associated valve lesions. Probably adjunctive therapy that might answer and help us reduce the mortality. So why do I say that revascularization alone may not benefit at all? Because blood flow to subendocardium is less as compared to subepicardium. Please remember that. Even after revascularization, the distribution of blood flow to the subendocardium remains low. Extent of reversible hibernating myocardium, I don't think we can do it an absolute number that this much is the extent of hibernating myocardium, even with the best modalities available. We have to look into associated structural defects, and other therapies might as well help better than revascularization. And yes, we should always keep in mind the effect of scar burden on mortality. But is complete revascularization really possible? I would say no. And guideline-directed medical therapy, actually it acts beyond the epicardial coronaries, and that is why it competes very well with revascularization in both CABG and PCI. So this is one image published in JACC, a heart with 67 stents. I think no patient in India or in any interventional cardiologist would want this or afford this. Possibly the patient missed optimized medical therapy. So if I have to conclude, the evidence till date, it says coronary physiology and myocardium is very complex beyond the current literature and understanding, and there is still a lot of scope for exploration. Incomplete revascularization is more common with PCI. Guideline-directed medical therapy, it acts beyond epicardial coronaries. Viability or ischemia detection, it is actually unable to predict the treatment effects of CABG or PCI. If you talk of data, then 10 years data from Stitch, yes, it says that revascularization from CABG was much better, but that data actually now is outdated, I would say. No survival benefit with PCI in ischemic heart failure till date, except for left main disease and acute ischemic heart failure. Thank you.